So welcome everybody to today's Department of Cardiology Grand Rounds. My name is Martin Ugander. On behalf of Rebecca Kozor, who's off, got called away with some urgent clinical commitments, we'd like to welcome a big treat for us today in Professor David Brown from St. Louis in the United States. And David trained as an interventional cardiologist at the Cleveland Clinic and has an illustrious scientific, academic, and clinical career behind him, including being a co-founder, if I'm not mistaken, of Volcano, the company that makes the some of the invasive equipment that is used for physiological testing. He also has an outspoken presence on the internet as the Less is More cardiologist on Twitter, which makes it particularly interesting to hear his take on a simplified integrated physiology and evidence-based approach to stable angina. Warm welcome to you, David, and over to you.
Thank you very much, Martin, and thank you for the invitation. And I guess good afternoon, Sydney. Today is the first day of fall in St. Louis, so I'm guessing yesterday was the first day of spring in Sydney, so that's always a nice time of year. So I'm going to talk to you about what a career's worth of thinking about coronary disease, initially as an interventional cardiologist, and over the last 10 years as a general cardiologist who's concerned about resource utilization, over-testing, conflict of interest, and all the other things that go into some of our decision-making as regards to stable angina. So I have no disclosures. I was a founder of Volcano, but I got out of that position a long time ago. So the objectives of my Grand Rounds today for you are to review the historical origins of the current stable angina paradigm that most of us operate under, to discuss some of the inconsistencies and shortcomings associated with this paradigm, and to propose to you what I think is a much more simplified, integrated, elegant even, approach based on physiology and evidence to approach patients with stable angina. That indeed would be a paradigm shift if I could convince more people to consider this approach. So here's the outline. I'm going to give you some background, and then we'll talk a little bit about history, how we got to where we are, what the recent science tells us, how that science has uncovered some inconsistencies to the paradigm and some challenges that the paradigm cannot really explain. And then, as I mentioned, we'll end up with my version of a new simplified evidence-based approach to patients with stable angina. So as far as background, in the Western world, we generally consider the first description of angina to have been made by Heberden in 1768, which you see on the left here, which he describes as a disorder of the breast with strong and peculiar symptoms. But actually, about 1,000 years earlier, the Arabic poet Caius wrote this poem that I think is even more succinct in summarizing the symptoms of angina, where he says, "My heart is firmly seized by a bird's claws. My heart is tightly squeezed. When Lila's name flows, my body is tightly bound, is like a finger ring around the squeezing in the chest." So depending on what you want to take as the earliest description of angina, we've known about this disease for about 1,500 years. And this is not a rare disease. This is a very common disease. In the United States, about 4% of adults over age 20 have a diagnosis of stable angina. That's about 11 million adults. And in 2016, it was estimated the outpatient cost to be $21 billion. So that's about $2,000 per year per adult in the outpatient setting. So a lot of that is going to ischemia testing because that's the foundation of our diagnostic approach for these patients. And maybe that's not the right way to spend money, but I'll let you come to that conclusion at the end of the talk. So our current 21st century stable angina paradigm looks like this. You have a pipe that has an obstruction in the middle of it or somewhere in it. That leads to angina. If you then do a stress test, you will find an ischemic response on stress test. And that ischemia then portends an increased risk of death. You may think that this is not really how people think about stable angina, but I'm going to add a quote to the screen that comes from a so-called state-of-the-art paper published by the inventors of FFR in JACC in 2012. And they say, again, this is considered a state-of-the-art paper by JACC, that it is important to emphasize that in coronary disease, the most important factor related to outcome is the presence and extent of inducible ischemia. The italics are mine. A functionally significant stenosis generally causes anginal symptoms and is associated with impaired outcome. Therefore, functionally significant stenosis should be revascularized if technically possible. So that was 2012. You might hope that in the last 10 years, things have moved beyond that, but I will show you on the next slide the very recently published guidelines for the evaluation and diagnosis of chest pain. And you will see on this slide red arrows, which are pointing to points in the scheme where ischemia testing is part of the evaluation, and blue arrows where detecting obstructive epicardial coronary disease is part of the algorithm. So the opinions voiced in that state-of-the-art commentary in JACC in 2012 are alive and well in the 2021 guideline for evaluation and diagnosis of chest pain. The center of it all is still the diagnosis of ischemia, the diagnosis of high-grade stenosis, which then leads to revascularization. So when we think about what we want to do for our patients with stable angina, we definitely want to prevent them from dying and improve their quantity of life. But we also want to improve their quality of life. And by that, I mean relieving angina as much as possible. And so any proposed paradigm for the diagnostic and therapeutic approach to these patients should apply to the broadest possible spectrum of these patients, should be based upon contemporary understanding of the pathophysiology of coronary disease and ischemia, and should spend as little of society's money as possible, because no society has an infinite amount of money to spend on healthcare. All right, so let's go back in time about 100 years or so and review a little bit of history about how we got to where we are. And this history is really based upon two initially separate technological advances that became intertwined later in the 20th century, and that is coronary angiography and stress testing. So if we go back a little over 100 years to 1918, the first published article on the ischemic EKG changes associated with an episode of angina were published in the Lancet on October 5th, 1918. And you can see in the top panel EKG tracing when a patient who was hooked up to an electrocardiogram had chest pain. You can see profound ST depression and T-wave inversion. And then you can see the tracing as chest pain resolves. The ST segments come back to the baseline, the T waves become upright again, and essentially back to normal. So that was the beginning of the stress testing historical journey that I'll take you through very briefly. About 50 years after that, we have the first Kaplan-Meier curve looking at the effect of an ischemic exercise test versus a non-ischemic test. This was performed in 2,200 male life insurance applicants and was published in JAMA in 1967. And you can see, I don't know if you can see my pointer, but the non-ischemic patients have much better survival out to 10 years compared to the ischemic patients. And in fact, the non-ischemic patients have the same survival as age-matched healthy controls in the population. So you see that same Kaplan-Meier curve recapitulated on modern stress testing modalities. Almost every year, a paper will come out. I mean, you see the exact same curves in 4 different stress testing modalities on this slide, whether it be dobutamine stress echo, vasodilator PET, SPECT, thallium SPECT, or MRI perfusion. Whenever you have an abnormal test, you have impaired survival. Now, around that same time, this historic event, especially for somebody who trained in the Cleveland Clinic, occurred in Cleveland on October 30th of 1958. And that was the first, albeit accidental, selective coronary angiogram performed by Mason Sones when a catheter that he was attempting to do an aortogram with slipped into the right coronary artery and opacified very nicely, as you can see in this poor quality image, the right coronary artery. That began a new era in vivo diagnosis of epicardial obstructive coronary disease. And you can see that not too many years later, the extent of coronary disease was associated with survival. This is a study from University of Alabama, Birmingham, which in the United States was a very early large cardiac center based in Birmingham, Alabama. And you can see here the survival with single vessel disease is quite good, same as survival with no obstructive disease. And then it's worse if you have 2 vessel disease, and it's much worse if you have 3 vessel disease. And then a few years later, it was published that you could actually find patients with obstructive coronary disease by doing stress testing. And the more vessels you had disease, the more likely you're going to have an abnormal EKG stress test. And in that paper that was published in Circulation in 1974, there was a quote that I printed for you here saying the use of exercise stress testing has achieved wide popularity and can be safely performed in large numbers of people in the office, outpatient clinic, or hospital. So there you go. We're off and running with the the beginnings of the cardiology industrial complex here. And so by the early 1970s, we had a simple, widely available method to detect ischemia. We had an association between ischemia and mortality. We had an association between ischemia and obstructive coronary disease. And we had an association between obstructive coronary disease and impaired survival. So what is the next obvious thing to do? Well, you want to bypass the obstructive disease, get rid of the ischemia, and presumably improve survival. So you can see the surgeons were experimenting with bypass surgery almost immediately after Soanes did his accidental angiogram, and angiography began to become a standard diagnostic procedure. So throughout the 60s, surgeons were experimenting with different ways to do CABG. And by the 70s, they had embarked on CABG versus medical therapy trials, which you have to give them a great deal of credit for that. After only a decade since the beginning of the procedure, they were ready to do randomized trials. And these were the three major randomized trials of CABG versus what was very rudimentary medical therapy, in many cases consisting of beta blockers and nitrates only. So there was the VA cooperative study, the European study, and the CAS study, all done in the early to mid 70s, all with about 750 to 780 patients, almost all male. And only one of them showed a significant reduction in 5-year mortality. That was the European study. Neither of the American studies, the VA cooperative study or the CAS study, showed a significant reduction in mortality. Now, while these studies were going on, in 1976, there was this poster presented at the AHA by a guy named Andreas Grunzig, who first described the percutaneous dilatation of coronary artery stenosis. You can see the title of his poster. It's a good lesson for people not to be discouraged when they submit abstracts to the AHA and they don't get accepted as an oral presentation. It was hoped that PTCA, balloon angioplasty, and later PCI with stents would be a less invasive method to achieve the same benefits of CABG without the upfront morbidity and mortality. And it took the interventional cardiologists, because we're a little slower than the surgeons, 20 years to do a survival study. That was the RITA-2 trial that was published in Lancet in 1997. That didn't go so well. You can see here that the cumulative percentage of death or MI is much higher in the balloon angioplasty group than in the medical arm. Mind you, there were no stents or statins available at the time of this study. And the impaired outcomes in the PTCA group was generally attributed to complications of the procedure that were largely eliminated by stenting, namely dissection and abrupt vessel closure after the balloon angioplasty procedure. So starting about a decade after RITA, we have sort of the randomized controlled trials in the OMT stent era, starting with Courage that was published in 2007, almost 2,300 patients with a primary endpoint of death or MI. Then Barry 2D, published 2 years later, was limited to patients with diabetes that were thought to be a higher risk or known to be a higher risk cohort. That study had two separate randomization strata, so two studies within the study. One was a PCI versus medical therapy arm, and the other was a CABG versus medical therapy arm. It also had about 2,300 patients, but its primary endpoint was only death. FAME2 was published in 2012. That used the ischemia surrogate, FFR, for PCI guidance versus OMT, because it was thought that that being able to identify hemodynamically significant lesions in real time in the cath lab would aid in selecting the more appropriate lesions to stent, and that would improve outcomes. Unfortunately, it was stopped prematurely after only 888 patients because of an excess of urgent revascularization procedures, but not death or MI. in the medical therapy arm. And then more recently, we had ischemia, which was limited to patients with moderate to severe ischemia on stress testing. Again, a cohort known to be at high risk, randomized to an invasive versus conservative approach. The invasive could be PCI, could be CABG. The goal was complete revascularization, although as I've recently said on Twitter, that concept is kind of a joke. The N was a little over 5,000, and after much controversy, the primary endpoint was changed to a composite consisting of cardiovascular death, MI, hospitalization for unstable angina, heart failure, or resuscitated cardiac arrest. And even more recently, published or presented and published simultaneously at the recent TCT meeting is the REVIVE study, which was a PCI versus medical therapy study in patients with reduced EF and coronary disease that was published in the New England Journal either last week or the week before. Now, just a word about optimal medical therapy in 2022. It's more than pills. It includes pills, that is some form of antiplatelet therapy, some forms of disease-modifying therapy, some form of anti-ischemic therapy, but also major lifestyle interventions as well, including some form of healthy diet, a program of regular exercise, smoking cessation, blood pressure and blood sugar control, and maintenance of an optimal weight or BMI. So question number one is, does the current paradigm that is exemplified in the current guidelines and by that state-of-the-art commentary from Jack in 2012, does that paradigm of whenever you see an ischemic lesion causing ischemia, it should be revascularized, does that reduce mortality, which is one of our goals in treating our patients with stable angina? So here's a meta-analysis that I published last year with one of our WashU residents, who's now a cardiology fellow in California, looking at all of the revascularization versus medical therapy trials to date. I just added the revived at the end. Now, these aren't the total cohorts of some of these studies. These are only patients that had ischemia on stress testing. So for example, you could get into Courage, but you didn't have to have ischemia on stress testing. So from Bill Bowden, we got the subset of patients that did have stress testing that were ischemic. Same with the MASS-2, same with Barry 2D. FAME2, all of the patients that had an abnormal FFR underwent PCI. So if you're a believer in FFR being a surrogate for ischemia, all of those patients were ischemic. We had the stitch data ourselves, so we pulled out of the stitch data the patients that had ischemia on stress testing. And then in ischemia and ischemia CKD, ischemia was a requirement for entry, so all of those patients are included. And I considered all of the patients in REVIVE to have some degree of ischemia because they all had viability but impaired wall motion. You know, possibly not all of those patients had ischemia, but probably a high percentage of them did. So anyway, this is a forest plot of the meta-analysis using a random effects model, which is the most stringent model with the widest confidence intervals. And you can see here that the odds ratio for a benefit is almost 1 with very narrow confidence intervals and a p-value of 0.57. So after all of these studies, there is no evidence that revascularization improves mortality, despite how the guidelines are set up and despite what certain experts say. And this is based on these studies with almost 11,500 patients. So what seems to be going on here is we've been chasing revascularization, but that's just a marker for atherosclerotic burden. So this is data from the COURAGE trial, where they stratified outcomes in two different ways. By the amount of ischemic myocardium on the left, you can see here 0 to 5, 5 to 10, and greater than 10%. And you can see the survival curves are all basically superimposable with a very high p-value of 0.75. Now, when you stratify the survival curves by the extent of atherosclerotic burden as determined from the angiograms, you can see that the more extensive atherosclerotic burden you have, the worse your survival, the higher your risk of death, MI, or an acute coronary syndrome. So, the reason I believe that ischemia tracks with survival or is associated with survival is not because it's on the causative pathway, but because it's a marker of atherosclerotic burden, which is on the causative pathway. Because the more atherosclerosis you have, the more potentially vulnerable plaque you have that can rupture and cause fatal infarction, that leads to ultimately to death. And this was also looked at in a different way in the more recent ischemia study. This is a secondary analysis published in Circulation last year. And they divided the ischemia severity into severe, moderate, none, or mild, although there wasn't supposed to be anybody in the study that had none or mild. This is when the studies are read by the core lab, and you can see all of the confidence intervals overlap with 1, meaning that that the survival is not impaired regardless of how severe your ischemia is. However, when they look at CAD severity, and they had a different way to measure it, here divided, and you can see their definitions. The group with the most coronary disease had 3 vessel disease with greater than or equal to 70% stenosis, or 2 vessel with high-grade proximal LAD, and going on down to 1 vessel. And you can see that there is a statistically significant separation of the point estimates and confidence intervals here with a very significant p-value. So just reinforcing the point that severity is not the driver of mortality, CAD severity is. Now, before you say, well, if CAD severity is the driver of mortality, then patients should do better with revascularization. But of course, we know from the results of ischemia, that's not true. So the other thing that we wanted out of a paradigm for the diagnosis and treatment of patients with stable angina was to get rid of their angina. Since that's why they're showing up in our offices, because they have chest pain. But it turns out that PCI is not very effective at angina relief, even in unblinded studies. So this is a graph from a paper that Josh Mitchell and I published in 2017. Josh is currently a cardio-oncologist here in St. Louis at Washington University. And basically what we did is we took the COURAGE data, but we excluded the patients that had no angina at the time of randomization. If you recall, you could get into COURAGE if you had typical angina and an obstructive lesion, or if you just had an ischemic stress test and you didn't need to have angina in that case. So we just were interested in the 1,784 out of the 2,200 patients that had angina at the time of randomization. And then we wanted to look at different points in time at angina relief. So not angina improvement, but angina relief. So I'll walk you through this. So the black bars are OMT, the red is the PCI plus OMT. So at time 0, patients in both groups all had angina. So 100% of patients had angina. At 1 month, the PCI patients, 79% still had angina, and 90% of the medical therapy patients still had angina. Now so the incremental benefit of PCI in that case is about 11%. We don't know how to factor in the placebo effect, but we do know that both groups have less angina over time, to the point that at 36 months, there's no difference between the groups, but still more than half of the groups in each group, each randomization group, have angina. So you've had people that have had successful PCIs that initially only gets rid of about 20% of angina. And at 1 month, all of the hemodynamic benefit of PCI should have long been incorporated into the coronary physiology. So it's clear that you get that upfront benefit, but then over time, it must be the medical therapy that reduces angina in both groups, but still only to a rate of about 60%. Now you see the same thing in ischemia, really, which is another unblinded study, obviously, but one in which complete revascularization was part of the protocol. So this is from the paper by John Spurtis, the second paper that was published in the same issue of the New England Journal as the main paper. And they basically looked at the invasive patients in the invasive arm compared to patients in the conservative arm. This is at 3 months. So I just drew this line at a Seattle Angina Questionnaire frequency score of 30, which means close to daily angina. So if you revascularize a person with a Seattle angina score of 30, giving them an attempted complete revascularization, whether by PCI or by cabbage, the probability that they will be free of angina is 30%. And again, this is at month 3. So there's no long-term benefit of revascularization that takes place after probably the first few days. So 70% of patients still have angina that have been randomized to an invasive treatment with a mandate for attempted complete revascularization. And again, over time, these numbers go up, and the invasive arm always does better than the conservative arm. But again, it's certainly nothing to write home about that at month 36, 40% of patients are still going to be having angina in the invasive arm. And that's something that we don't tell our patients. Clearly, I've never heard an interventional cardiologist, including myself, tell a patient that was having angina every day that there's a 1 in 3 chance that we'll get rid of your angina with this invasive procedure. But that's what the data is. And again, this is unblinded. So it could potentially be worse than that, because we know from the ORBITA trial that was published in the Lancet in 2018 that compared single vessel PCI to single vessel sham procedure, that there's really no significant improvement in exercise time. This is at 6 weeks, which was the end of the study. There's no significant improvement in exercise time, time to 1 millimeter ST depression, time to peak oxygen uptake, Seattle Angina Questionnaire scores, Seattle Angina Questionnaire Quality of Life score, Duke Treadmill score, Canadian Cardiovascular Society angina grade. In fact, the only thing that got better in ORBITA was the stress echo. Patients didn't get better, but the stress echo got better. So shifting gears a bit, it's very interesting that this PhD thesis or MD thesis done at the University of Glasgow right around the same time that Soanes was doing his angiogram showed the difference in what coronary opacification looks like if you have 30 micron resolution compared to what you have on an angiogram, 300 micron resolution. So here you, on the left, you clearly see this very rich network of microvasculature. And here on the right, you see the large epicardial vessels and none of the microvasculature, which is what is seen on a coronary angiogram even today. So, I think that this is sort of the missing link that even though that that thesis was published around the same time as Soanes' first angiogram, we've been very slow in cardiology to integrate the coronary circulation into a single entity. We tend to divide it into the epicardial arteries that we can see and everything else that we can't see. The epicardial arteries we can see, we can stent, and we get paid for stenting. The other things we can't see, we don't get paid for, and so they have been largely ignored, despite the fact that, as you can see here, the resistance to flow provided by the large epicardial arteries is only 5%, and 95% of the resistance to flow is these downstream smaller prearterioles and arterioles. And in fact, this is a very nice study that was published in the Canadian Journal of Cardiology, getting back to the angina story after successful PCI, that if you look at microvascular function in patients that have persistent angina 6 to 12 months after having a PCI, and you measure coronary flow reserve invasively, and you consider the coronary flow reserve less than 2.5 to be indicative of microvascular disease, you can see in the angina group, the group that had persistent angina 6 to 12 months after PCI, that over half of them had microvascular dysfunction in the target vessel that was treated with the PCI, and another 30% had microvascular disease in another reference vessel other than the target vessel. So, this is something we don't think about, we don't talk about often enough, and I'm going to get into it a little more in a few slides, but microvascular dysfunction and epicardial obstructive disease occur together, and it makes sense when you think about it, because the same evil humors that are circulating through the epicardial vessels and altering the physiology of their endothelial cells and smooth muscle cells is also going downstream to these smaller vessels. So it makes no sense that they would survive unscathed from the atherogenic effects of individual patients. So, another question we want to ask is, does the current paradigm apply to the broadest spectrum of stable angina patients? So that answer is clearly no. This is this classic paper published in the New England Journal in 2010 by Manesh Patel from Duke, where they looked at 400,000 patients that had had non-invasive testing, symptoms recorded, and underwent coronary angiography. And if you just look at the blue bar in the positive, so these people had positive non-invasive testing, they had classic symptoms of angina, yet only 50% of them had obstructive coronary disease. So I remember when this paper came out and people were saying, well, the ones that didn't have obstructive coronary disease, those are false positive tests. Well, they're false positive in the sense that stress tests were sort of calibrated against obstructive coronary disease in the early days. but they're not false positives when you consider that microvascular dysfunction can give an ischemic stress test result. So they're telling us something that we don't know how to interpret, but they're not false positive. The majority of them anyway. And here's a paper from Scotland where they actually looked at patients that were admitted for invasive evaluation of chest pain and divided them after catheterization into those that had obstructive coronary disease, which was about a little more than half, and those that had ischemia without obstructive coronary disease, so-called ANOCA. And then they did invasive physiologic testing. And they found that in the ANOCA patients, half of them had microvascular dysfunction, similar to what I just speculated with the Patel paper in the New England Journal. 17% of them had vasospasm and 20% had mixed microvascular and vasospastic angina. And then 11% didn't have any identifiable cardiac abnormality. So we tend to, unfortunately, think of these two entities as separate silos. You either have obstructive disease or you have ANOCA. And if you have one, we can fix you with a stent. And if you have the other, we'll send you somewhere where somebody has the patience to play around with medications. And in fact, the same 2021 guidelines sort of take this separate silo approach, that there is sort of an add-on algorithm after you've excluded epicardial disease, that if you are then go into the suspected ANOCA algorithm, where you go through testing that is done after you've gone through testing to rule out obstructive coronary disease. So I think this is all, harmful. It perpetuates a physiologic misunderstanding and oversimplification of coronary physiology. And in reality, it takes the entire coronary artery to produce ischemia, and probably in most cases. And in fact, here's a kind of a cool article from Van de Hoof that was published in Heart in 2014, where they looked at the prevalence of reversible perfusion defect on perfusion imaging. And if you just look at the three columns on the right, so if you take somebody that has a lesion in their epicardial coronary disease with an FFR of less than 0.75, so by convention, that's physiologically significant, they have low or intermediate degree of microvascular dysfunction, they will not have a very high incidence of reversible perfusion defects. But if they have a high degree of hyperemic myocardial resistance, meaning microvascular dysfunction, that's when you see a large number of reversible perfusion defects. So you need sort of the double hit to get the abnormal perfusion defect that we recognize as ischemia. A healthy microvasculature in the presence of a significant epicardial obstruction will not give you an abnormal stress test very often, probably 15 to 20% of the time. And we know that the abnormal CFR is associated, or coronary flow reserve, meaning microvascular dysfunction, in and of itself is associated with an increased risk of mortality and major cardiovascular events, with a mortality risk of almost fourfold over patients that don't have abnormal coronary flow reserve, and a MACE rate of about 3.5-fold increased if you have abnormal CFR. So unanswered questions that for those of you looking for important research projects to do, We still don't know what percentage of patients with angina and ischemia have both obstructive CAD and concomitant microvascular dysfunction. All the studies I showed you were very small sample sizes. We don't know what percentage of patients with concomitant obstructive coronary disease and microvascular dysfunction have their symptoms and outcomes determined by microvascular dysfunction. It would appear, both from the COURAGE data and the ischemia data, that 60 to 70% of people have their angina driven by microvascular dysfunction after their epicardial disease is treated with stenting or bypass surgery. So, we frequently see this diagram on the left in review articles on coronary disease or chest pain or microvascular disease, which suggests that these are fairly pure categories and it's only the rare patient that's in these overlap groups, where in reality, I think the drawing should be more like this. I think almost all patients with obstructive disease have microvascular dysfunction, and maybe a small number of those have vasospasm superimposed upon that. So this is how I approach patients that come into my office with stable angina, and I just present this for your consideration. So I get a coronary CTA, and although I hate to order imaging testing, I find this one to be very helpful because the patient actually has no atherosclerosis on it. Then you can basically focus on primary or primordial prevention. If they have non-obstructive coronary disease, you can start them on medical therapy. If they have obstructive coronary disease, you can start them on medical therapy. If they have left main coronary disease, that's significant, you can refer them for PCI or CABG. If they have an EF less than 35%, you can start them on guideline-directed medical therapy and refer them for CABG for a survival benefit if they're appropriate candidates. And then the patients in these two categories, so somebody that has refractory symptoms on OMT that has obstructive coronary disease on their coronary CTA, they can be considered for PCI or CABG for persistent symptoms, depending on what their anatomy is. And if they have non-obstructive disease, they can be evaluated for microvascular dysfunction or spasm for persistent symptoms. I do the assessment for microvascular disease non-invasively using PET because I can only interest our interventional cardiologists in doing one procedure in the cath lab, and that's acetylcholine provocation for spasm. So that's how I proceed, but you could do both studies in one invasive procedure if your cath lab crew was interested in doing that. So in conclusion, in my view, stable angina is a symptom of chronic coronary macro and microvascular disease. In most cases, ischemia and obstructive coronary disease are markers for atherosclerotic burden and not the direct causes of morbidity and mortality. They should not be the targets of therapy, and we should always remember that association is not causation. I also believe, as I mentioned, that dichotomization into obstructive coronary disease and ANOCA is overly simplistic, inefficient, and counterproductive, and that stable angina may be successfully treated with an integrated diagnostic and therapeutic approach with limited testing using medications, risk factor control, and lifestyle modifications in most patients. So I thank you for your attention, and I'm happy to answer any questions, criticisms, or rebuttal.
Thank you so much, David, for that tour de force, and not to mention the history behind how we're doing today. I can imagine it might have awoken some questions from the audience. And while they think of that, I'd like to ask you, so a question that comes up often in these settings is the patient's of the patients. So how patient can we be to await for results? And some people who might not be patient would want to say, hey, I'm not going to wait around for OMT for months. I need something now. I need a stent now. What would you say to that kind of an argument?
I would go over the results. I would ask them, do you expect a stent to take away your symptoms completely? And of course, they're going to say yes, because, they sort of understand the clogged pipe paradigm, and you can't expect them to understand much more beyond that in most patients. But if you say there's only a 1 in 3 chance and maybe it's less than that if you believe the ORBITA trial, that a stent is going to take away your symptoms, I tell them that. And then I use the famous cardiologist, the interventional cardiologist Greg Stone's own paper to show that there's an ongoing event rate of 2% per year ad infinitum caused by the stent itself. So if you have your stent in for 10 years, you have a 20% risk of stent failure of some sort. So it is not a benign procedure, and it's not a benign device to leave in. And, most patients, especially if they're on no medications, most patients get some improvement quite quickly. I do it very quickly. I titrate up over a month. Usually patients are happy with that.
Thanks a lot. Any thoughts, Peter? I'll repeat the question because of the microphone. Yeah, go ahead.
My understanding from the talk was that with medical treatment, the angina progressively gets less. Could I have some elucidation of that? Why do patients on medical treatment get less angina as time goes by?
Yeah, so the question is, why do patients on medical treatment get less angina as time goes by?
Well, I think because you're improving their microvascular function, which you saw in that COURAGE data that I showed, that angina went down over time in that group, or the percentage of patients that had persistent angina went down over time. That was also true in ischemia. And I think that's one of the long-term benefits. Unfortunately, it's not super short-term, but I think that's one of the long-term benefits of all the things that we do that we consider OMT, whether it's statins, whether it's, angiotensin receptor blockers, whether it's exercise, whether it's weight loss, whether it's blood pressure control, et cetera. I think all of those things improve microvascular function. They're not going to improve the epicardial stenosis. So if your symptoms are getting better, it could only be because your microvasculature is getting better.
Go ahead.
Do we really understand what is actually going on when we have microvascular dysfunction? Do we know anything about the molecular structure or even the cellular structure that underlies it? I always find it very hard to treat something I can't in any way directly visualize or even conceptualize. It's a phenomenon, but really, I find it hard to call it a disease or a dysfunction because I can't identify what it is.
Yeah. Well, we talk about endothelial dysfunction in the epicardial disease. When somebody goes to the cath lab and they have slow flow in their epicardial vessels, we talk about endothelial dysfunction. It's probably actually more endothelial dysfunction in the microvasculature when you see that. But there's endothelium that is responsible for appropriate vasodilation. When that endothelium via the nitric oxide pathway, when that endothelium is injured by the same things that injure endothelium in the epicardial vessels, you can have failure to dilate to appropriate stimuli. But microvascular disease is a heterogeneous thing because you can also have normal microvascular function, but if you have severe, for example, left ventricular hypertrophy, you can have external compression of the microvasculature, which prevents it from dilating appropriately, even though the microvasculature itself is physiologically normal. So there is a lot we don't know about microvascular function. It's an area ripe for research. The other very interesting thing that some people are looking into is whether microvascular dysfunction is a systemic disease. There's some evidence of microvascular dysfunction in the brain. And this is, another area that's people are just starting to look into.
Thank you, David. Yeah, go ahead.
I think it's been appreciated for a while that there's microvascular dysfunction and that people kind of could investigate that in a cath lab with things like IMR. But then you see our interventional colleagues not really doing IMR regularly in many people. Why do you think that is? And do you think with perhaps a discovery of a therapeutic intervention means that it would actually change management? Would that see people more investigate microvascular dysfunction?
Did you hear the question?
I heard it. Yeah, it's a great question. I think for a long time, the equipment to do CFR, the flow wire, was not very user-friendly. I think that equipment has improved, but it disrupts the flow of the modern cath lab. The modern cath lab is there to stent people and now to do TAVR. To generate revenue for the hospital. And these things, they slow throughput, which is why I do it with PET. But, there is, I'm always shocked on Twitter whenever I see an interventionalist talk about microvascular dysfunction. I know there's a trial of a new device that they're getting ready to do. And for example, there's a trial of a coronary sinus occluder that's starting up soon in the US. I don't know if it's international or not. And so all of a sudden, interventionalists on Twitter are talking about microvascular dysfunction because it may be a target for a new device therapy. Which is one of the reasons that I wasn't unhappy to leave interventional cardiology, because it's supposed to be about the patient. It's supposed to be about the intellectual challenge to understand what's going on with our patients and to make them better. But it's like pulling teeth to get them interested in this disease. And one of it, part of it's that we don't teach very much. Even going back when I was a fellow, it was never mentioned. But, in the WashU fellowship, it's hardly mentioned. And nobody considers, everybody considers it to be rare, to be a disease of women, which is also another source of bias, unfortunately. One, it's not rare. Two, it's not a disease of women. In my chronic chest pain clinic that I ran at WashU for 8 years, I had more men than women in my clinic. So, it goes back to education and, trying to deal with the interventional mindset.
Thank you.
You had a question?
I think Chris.
No?
Where does the phenomenon of myocardial hibernation sit in your new paradigm? Does it influence how you deal with the stenosis that may be causing hypokinesis in a muscle that's viable?
Well, that's a very interesting question, given the results of Revived, where all patients had viability, all patients had severe obstructive coronary disease, and the patients randomized to stenting had the same degree of improvement in their EF as the patients that were randomized to medical therapy. So I don't know what I think about viability and hibernation anymore. the original definition of hibernation was a surgeon put a graft on a artery to a non-functional or a hypofunctional segment of myocardium, and the myocardium started contracting normally again. So it's definitely a real phenomenon, but it's very confusing given the results of Stitch, where the outcomes weren't a function of the viability. But I mean, I would say if you have somebody with, significant wall motion abnormality where you think they may have hibernating myocardium and they're symptomatic from it, and they have a very high grade coronary lesion, I would probably fix it. But, if you have a wall motion abnormality that is subtended by an artery that has a 70% stenosis, that myocardium is not hibernating, because a 70% stenosis gives you enough blood flow at rest for normal myocardial contraction. So to have true hibernation, you need a lesion 90 to 95%, nearly subtotally occluded. And in that case, but without any data, I would probably refer somebody to get revascularized.
More? Yeah. go ahead.
Just ask perhaps a unusual question about aspirin. So in this situation, which you include aspirin, its role in primary prevention is now being questioned. And so,
Yes.
so this is primary prevention or not?
So you're asking me if somebody that has isolated microvascular dysfunction and symptoms on the basis of that, whether there's any evidence to put them on aspirin, right?
Yes, with stable, even epicardial coronary disease, but without previous infarction or unstable angina.
Yeah, that's a tough one. It's sort of one, it's not primary prevention, it's not secondary prevention, it's something in the middle. But I mean, if somebody has 50% or more stenosis in a coronary, I put them on aspirin.
As we round off, I'd like to leave with a question to ponder. We've all met the patient that had some kind of non-emergent chest pain and sought elective care for that and got worked up, and they found a stenosis, whether it be on the CT or the express echo or the invasive angiogram, and they got their stent, and you were involved in that decision-making process. When I think about these things that Professor Brown brings up, I start thinking about this changing paradigm of how maybe we shouldn't be doing that in every single one, or rather that should be the exception and the rule. And I'd ask you to ask yourself, is that something you're doing currently, and that's something you want to continue doing in light of this data? I don't know that we can answer it right here now definitively, now that we're sort of out of time, but I'd like to leave with that thought process, because I think we have a culture across Australia and across interventional cardiology internationally of putting the stent first, and that might not be the solution as indicated by the data presented. So with that, thank you so much, David, for joining us. It's been a very fortunate opportunity for us to hear your distillation of a long career thinking about these things. And thank you so much for joining us today.
Thank you. It was an honor.
Thank you. We'll be closing the call now. Take care. We'll be in touch.
Okay.